Locking compression plate, LCP. Percutaneous plate fixation of the tibia and fibula in a distal multifragmentary fracture of the lower leg. The MIPO technique. These are the x-rays of a 55-year-old female skier with a metadiaphyseal multifragmentary fracture of the lower leg, with radiation into the upper ankle, which is not suitable for a medullary nail internal fixation. There are concomitant second-degree anteromedial closed soft tissue lesions. The fracture is simulated on the plastic model. There are two large curved wedges on the tibia and a two-level fracture with small curved fragments on the fibula. If fractures close to a joint are stabilized with conventional non-locking screw and plate systems, there's a danger of a secondary loss of reduction due to successive loosening of individual screws in the section close to the joint. Anchored, stable angle screws cannot loosen under cyclic loading and so prevent this secondary loss of reduction. For the stabilization of the fracture model, a narrow 12-hole 4.5/5.0 LCP is available for the tibia. The fibula is stabilized using an 11-hole 3.5 LCP. With percutaneous internal fixations with LCPs, the preoperative planning is decisive. First, the fracture of the tibia is stabilized. The slightly pre-contoured 4.5/5.0 LCP is primarily fixed distally, close to the joint with a 6.5 mm cancellous bone screw. After checking the correct reduction regarding length, axis, and rotation, proximal fixation is performed with a monocortical self-drilling locking head screw. Then comes final fixation, distal with self-tapping and proximal with self-drilling locking head screws. The fibula is stabilized with the slightly curved 3.5 LCP. The start is proximal, with a locking head screw for the primary anchorage of the plate. Then a conventional cortex screw is placed in the distal section to draw the plate close to the bone. Definitive bridging is done by placing more locking head screws at the lower and upper ends of the plate. Drawing in and fixation of the broken-off segment with a cortex screw is optional if the segment is still seriously dislocated. Some surgeons would fix the fibula first to give alignment and length, which makes percutaneous stabilization of the tibia much easier. These implants are available for use on the model. For fixation of the tibia, the following instruments from the large fragment set are needed. The 3.2 mm drill bit, the 6.5 mm tap for cancellous bone screws with T-handle for quick coupling, the appropriate drill sleeve, the depth gauge, and the hexagonal screwdriver. The insertion of locking head screws requires these instruments: two threaded LCP drill guides, the 4.3 mm drill bit with length markings, the 4.5/5.0 LCP universal drill sleeve, the screwdriver shaft with the quick coupling, the torque-limiting screwdriver, and screw-holding sleeve. The anatomical landmarks are drawn on the model. They are the joint cavity of the upper ankle, the medial malleolus, the edge of the tibia in the region of the shaft, and the approximate position of the fracture zone. Instability is clearly visible in the fracture model. For this exercise, the reduction is checked visually, but in reality, this has to be done through image intensification. Marking of the upper ankle with a K-wire. In accordance with the fracture planning, the distal section of the LCP must be slightly bent and torqued. With the conventional method using standard screws, inaccurate bending of the plate inevitably leads to loss of primary reduction because the bone is drawn to the plate. This disadvantage does not arise if an LCP with locking head screws is used. Therefore, this plate does not have to be pre-shaped absolutely anatomically. At the proximal and distal ends of the plate, the planned incisions are marked in over about 3 of the plate holes. Using the marking as a guide, the soft tissue is incised. The periosteum is not opened. A threaded LCP drill guide placed on the distal end of the plate is ideal as a guiding instrument for pushing in the plate in the distal to proximal direction. Depending on the situation, a tunnel first may need to be created with a blunt instrument. The proximal end of the plate is aligned onto the middle section of the shaft, and a second threaded LCP drill guide is screwed into the second hole from the top. The planned point of entry of the 6.5 mm cancellous bone screw is 1 cm proximal to the ankle. It is drilled with the 3.2 mm drill bit, parallel to the K-wire inserted into the joint. The depth is measured. The thread is cut with the 6.5 mm tap for cancellous bone screws. And the cancellous bone screw with continuous thread is screwed in. The screw is still not completely tightened. This allows the definitive reduction of the fracture in regard to length, axis, and rotation. This alignment can be undertaken over the plate with the aid of a threaded LCP drill guide. Preliminary retention of this reduction is achieved by inserting a K-wire through the threaded LCP drill guide. The plate is fixed onto the shaft through the most cranial hole in the plate, with a monocortical self-drilling, self-tapping, locking head screw. The adjacent cortex is drilled with the universal LCP drill sleeve to accommodate this screw. A blue monocortical self-drilling, self-tapping locking head screw is inserted using the air drive. The last few turns of the screw must be made by hand with the torque-limiting screwdriver. The K-wire and the threaded LCP drill guide in the region of the shaft are removed. After this surgical step, the final axial correction of any anti- and retrocurvation can be made. Here it's checked visually, but in the clinic it has to be done by image intensification. The further stabilization is carried out entirely with locking head screws. In the metaphyseal section, green self-tapping screws are used, for which holes are drilled with the 4.3 mm drill bit through a threaded LCP drill guide. The length of these screws can be read off on the scale after the drill is slightly withdrawn. The selected screw is inserted with the air drive. Here too the last few turns are carried out with the torque-limiting screwdriver. If the LCP holding sleeve is fixed over the head of the screw, the bone fragment that is being held can be drawn a little farther onto the plate with this sleeve. Whether this is necessary depends on the position of the fragments. After withdrawal of the LCP holding sleeve, the green locking head screws are finally firmly tightened. After identical pre-drilling, a further green locking head screw is inserted through the third hole in the distal end of the plate. The plate is stabilized in the region of the shaft with two more monocortical self-drilling locking head screws. This is the situation after completion of the internal fixation on the tibia. The fracture zone is bridged by means of internal fixation. The slight protrusion of the plate is desirable in order to prevent as far as possible any compression of the periosteum. Here is the clinical picture after this stage of the operation. In this case, a lag screw was also inserted through the plate to fix a large lateral curved wedge. Fractures of the distal fibula, close to the joint, should be stabilized, because any defective positioning could lead to an incongruence in the upper ankle. The LCP instruments needed for the internal fixation of the fibula are 2 threaded LCP drill guides, a 2.8 mm LCP drill bit with length markings, a torque-limiting screwdriver attachment, a screwdriver shaft, and a detachable handle. From the small fragment set, the 2.5 mm drill bit, the 3.5 mm tap for Cortex screws with handle, the 3.5 universal drill guide, the depth gauge, and a small hexagonal screwdriver are selected. Here, too, the corresponding landmarks were drawn in with the approximate location of the fracture. The 11-hole 3.5 LCP with the distal end bent slightly outwards serves as reference for the planned incisions, which are first marked in. The soft tissues are incised at the appropriate sites. If possible, the periosteum is not touched. The selected LCP is again inserted in the distal to cranial direction after previous tunneling of the plate bed. A threaded drill guide again serves to hold the plate. In this model, the distal end of the plate is aligned at the level of the upper ankle. Preliminary fixation is carried out with a K-wire inserted through the threaded drill guide. The K-wire should lie as centrally as possible in the fibula. After a further threaded drill guide has been screwed into the most cranially situated hole in the plate, the correct length of the fibula is aligned. In reality, this has to be done by image intensification. The plate is initially fixed cranially onto the shaft of the fibula with the toothed reduction forceps. A green locking head screw, for which the hole is drilled using the 2.8 mm drill bit, is placed in the uppermost hole in the plate. The length is read off on the scale. The threaded drill guide is removed, and the selected locking head screw is inserted using the air drive fitted with the torque limiting attachment. The last few turns are again made by hand, so the air drive is disconnected from the torque limiting attachment and the handle is attached. The locking head screw is completely tightened. In the distal region, the plate should lie as close to the fibula as possible to avoid restriction of the soft tissues. Therefore, a conventional cortex screw is first used. The hole is prepared with the 2.5 mm drill bit with measurement of the length, tapping of the thread, and insertion of the selected cortex screw. In this way, the fibula can be drawn towards the plate as desired. The K-wire and the threaded drill guide are removed, and a blue monocortical self-drilling locking head screw is screwed in. To complete the internal bridging fixation, after pre-drilling, a second self-tapping locking head screw is inserted into the proximal section. Should the intermediate segment still be clearly dislocated, it can be drawn onto the plate with a cortex screw inserted percutaneously. For this, the hole is drilled with the 2.5 mm drill bit through the 3.5 universal drill guide. The hole in the plate and the drill hole in the bone can be marked by means of a K-wire. The drill guide is now rotated and slid over this wire, enabling the thread to be created with the 3.5 mm tap for cortex screws. The selected cortex screw is inserted, so that the intermediate fragment can be drawn onto the plate and fixed. This is the clinical appearance after completion of the percutaneous internal fixation of the fibula. To finish the exercise, the soft tissue mantle is opened up. This reveals an internal bridging fixation of this multifragmentary fracture of the lower leg, which is correct for length, axis, and rotation. These are the post-operative X-rays of the 55-year-old patient. The internal fixation was carried out with conventional LC-DC plates. X-ray follow-up after 3 months shows the unchanged position of the fracture and the onset of indirect healing. When the implants are being removed, certain screws may be so firmly anchored in the plate that they cannot be extracted with the conventional screwdriver. To remove such screws when the hexagonal head is damaged, 2 instruments are available: the 2.5 mm conical extraction screw with left-hand thread and a 2.5 mm drill bit for metal. The conical extraction screw must be screwed into the damaged hexagonal head of the screw anti-clockwise. This can be done with the air drive at slow speed, or by hand, using an attached T-handle. In rare cases, this procedure is not sufficient. The screw on the right of the picture is removed by this method. In the case of screws that are difficult to remove, the hexagonal socket is deepened with the 2.5 mm drill bit for metal until the conical extraction screw is finally wedged in firmly and the locking head screw can be removed. In this way, it should be possible to extract all the screws from the plate.